Yes. Your time has started. And here is your question. Right. So if you have read and understood, considering it critical care scenario, kindly please tell me how would you manage this patient now?
Yes, ma'am. Considering this scenario, I will manage the patient according to PIS protocol,
Yes.
and I will go for ABC approach. And during checking the breathing and ventilation status,
Yes.
I will check the saturation of the oxygen saturation of the patient. I
Okay.
will auscultate the chest and check if there is any diminished breath count on the affected side, and if there is any raised JVP present or not, and trachea shifting present or not. And
Okay.
I will start 15-liter oxygen per minute, and I will go for immediate needle chest immediate tube thoracostomy in affected site, fourth or fifth intercostal space at the level of nipple, just anterior to mid-axillary line. And after that, I will monitor the patient's
Yes. How
oxygen
frequently?
saturation
Yes.
as well as breath sound.
How frequently would you be taking care of the vitals for this patient?
Ma'am, I will check this hourly.
Okay. Why do you think the patient has suffered with the shortness of breath, and how would you take care of that?
Ma'am, considering the scenario, my assessment goes for tension pneumothorax.
Okay.
And the next question, ma'am.
Yes. How should this tension pneumothorax be managed?
I will
According to the
first
NICE
immediately.
guidelines, yes.
I will immediately go for a needle thoracostomy, and
Yes.
then I will insert the tube thoracostomy. I will do the tube thoracostomy under ultrasound guidance,
Yes.
and do a procedure just X-ray
Yes.
to exclude to see the status of pneumothorax and position of the
What are the types of
yes, ma'am, to
pneumothorax
see the
that you are
status
aware
of
of?
pneumothorax.
What are the types of pneumothorax that you are aware of?
Then it may be classified as open versus closed,
Very good.
uh, sim,
Yes.
simple versus tension pneumothorax, and
Good.
primary versus secondary.
How would you differentiate simple pneumothorax from tension pneumothorax?
In case of tension pneumothorax, there will be trachea and mediastinal shifting, and towards the opposite side, and
Yes.
there will be tachycardia, hypoxia, and severe chest tightness, and there will be raised JVP.
Okay. If you can tell me this tension in this patient, which type of pneumothorax would there be? Is it simple pneumothorax or
The
tension
scenario
pneumothorax?
goes for tension pneumothorax.
Okay. In when a patient is suffering from tension pneumothorax, what kind of in what kind of shock patient can be? Or if you will do the ABGs, yes, how would the patient's ABG?
There will be obstructive shock.
Okay. And if you'll take the ABGs, how would you interpret that?
And there will be well, can I get back to this later?
Okay, how would you write? You told me how would you manage that? What type of pain management would you take care of, or how would you take care of the pain?
I will I will manage the pain according to WHO pain ladder.
Yes.
I will go for non-opioid analgesics first,
Yes.
and then weak opioids, and then if not controlled, then I will go for strong opioids.
Okay. How would you take care of the nutrition of the patient during the management?
I will go for enteral feeding.
Okay. How frequently?
Ma'am, 2 hourly.
How? Okay. And what are the components of the nutrition that you'll pay extra attention to?
Carbohydrate 60%, protein.
How long would you be giving? How long would you be giving enteral feeding? Okay, can you tell me? Okay, you've inserted, you've managed. Tell me what is the technique that one should use according to the NICE guideline for removing the central line which has been inserted?
For removing, I will put the patient's head down to
Okay.
prevent air embolism.
Yes.
And to prevent any kind of line infection, I will ensure the proper hand hygiene, and I will properly prepare the skin, and I will ensure that all the protective barriers are maintained,
Yes.
like sterile gloves, gown, cap, mask, plus sterile drapes.
Yes.
And as long as the central
Okay.
line is in place, I will
Can you
properly maintain
please,
central line maintenance
yes,
practice.
can you please tell me 5 indications when central line should be removed?
If there is cessation of
Yes.
the resuscitation procedure, or any kind of
Yes.
potassium-rich drugs, or TPN, or cardiac support needed for through inotropes,
Yes.
and if there is any line CV line sepsis,
Yes.
and when
Or
patient will
infection.
get discharged, I will remove the CV line.
Okay, and if patient was getting you've already told me cessation of the cardiac support inotropes. So all right. Can you tell me what are the complications of central line insertion can occur?
There may be CV line infection.
Yes.
There may be air embolism, thrombosis, any kind of iatrogenic arterial injury that may lead to hemorrhage, pseudoaneurysm, or hemothorax. Pneumothorax may happen, and on right atrium puncture may be done iatrogenically, and that may lead to cardiac tamponade, and cardiac arrhythmia may happen, and left-sided interjugular vein cannulation may lead to thoracic duct injury that may lead to chylothorax.
Can you tell me the landmark for internal jugular vein?
Landmarks, there are 3 landmarks: mustard process, and carotid pulsation, and the gap between the 2 heads of sternocleidomastoid muscle. And I will feel the carotid pulse at the center of these 3 points, and I will insert the cannula just lateral to the pulse, carotid pulse, making a 30-degree angle with the horizontal towards the ipsilateral nipple.
There are 2 investigations, very important, when a patient presents with shortness of breath. Can you name those 2? Simple and important. One is chest
I will go
X-ray
for
and one is ABG.
chest everything. Ma'am, this